So I do want to say that it's wonderful to be asked here to do the patient care discussion debriefs. I think it's more of a novel thing that we've been talking about. Lots of trauma-informed care when patients come to us, right? Already having experienced trauma, but how do we actually manage that after a severe event to help patients move forward? And we'll talk a little bit about the reasons for that and ways that we can do it. And I do want to absolutely credit Kaylee Summers, who did a lot of this work. She's a licensed social worker who worked with us on the toolkit on all these patient tools. And I know she wanted to be here today, but she wasn't available. So she sent me your way to do this discussion. So I'm doing my part and her part together, and I hope I do it justice. But you can see all of Kaylee's materials in the toolkits. Next slide. No disclosures, and you already did my intro, so we can go ahead and skip here. So just a little bit of background on why and how we were able to develop some of these things in all of our collaboratives for, I don't know, 2 million years now. We always talk about how do we support and debrief with patients, but never actually supplied any resources. Like, please go ahead and do this, but we didn't have resources. So we were given this money by the NIH to work through sepsis, different materials with sepsis, and it was a different planned collaborative in that we had a community leadership board that helped lead this project. And so it was a chance for us to not only identify clinician barriers, which is what we've typically done in our collaboratives, but to really look at patient barriers from the patient perspective. We've certainly had patients before participate in some review of toolkits and some vetting of materials, but this was really a ground up patient level piece where we had developed all of these materials directed to patients by patients. So it was really exciting, and we got a lot of qualitative data out of this. And together with the clinical teams and the community and patients with lived experience teams, we're able to design all of these resources together as opposed to, one side vetting the other side. So it was a really unique experience. And as we were going through it, we realized that while this is part of the sepsis work, this is applicable to all severe maternal events and is not just relegated to sepsis. So we've made these pretty broad in that they can be applied to all severe maternal events so that it's not, lost in the sepsis work. To be fair, though, when you find that the resources, they are going to be attached to the sepsis toolkit and on the sepsis page because that's the way it was funded. But just know you can use this for hemorrhages and things like that, as Michelle alluded to being one of the most common ones that we use it for. Next slide. So when we revised the toolkit, the original toolkit came out in 2020. This revision came out in 2025. And as I mentioned, this was a little bit different in that we really partnered with patients and community advocates. And you'll see that if you've used our toolkits in the past, how different this one is and more robust on the patient side. We also had a big, large-scale data set in order to hone into some of the more specific pieces of the sepsis pathway, how we look at severe infection, how we actually diagnose sepsis. So we had the benefit of doing all of that analysis. And we led an 18-month collaborative during the revision of this toolkit. So it was really informed by the hospital and patient lived experience in real time as we were applying some of these structure measures and implementation techniques. Next slide. So we're going to talk a little bit about birth trauma and its impact. Next slide. So birth trauma, what is that? And it's any distressing event during or related to birth that overwhelms the nervous system's ability to cope and causes ongoing distress. And this was noted in Michelle's talk as well, is that sometimes our perception of what should be traumatizing during a case is very different than other staff members or the patient's experience, right? So it's kind of one of those details in which birth trauma is what the patient says it is, right? And that can be impacted by their previous health experiences, previous life experiences, right? So we really have to be, communicating with our patients and being very perceptive and following up, even when we think the patient doesn't need it or maybe they don't speak very much at all. Next slide. So birth trauma is wide-ranging and subjective. It can do with just a lack of autonomy, right? And so this has been a real highlight of equitable and respectful care, talking about, how do we address patients when we're going to touch them, right? Like very minor things that we didn't do in the past. Really thinking about dignity, respect, informed consent, shared decision-making, how those things go in the patient perception of their care and how that can cause trauma with their hospitalization or their birth. The threat or perceived threat of life or safety. So even something saying like you bled more than we expected you to bleed, that can stick with that patient as I almost died, right? And during childbirth, even though maybe that hemorrhage wasn't as significant to us. But sometimes the words that we use can have that patient carry that experience past that birth into being something that they're carrying around as a piece of birth trauma. And then obviously any unexpected outcomes or events, transfers to NICU, transfer to ICU, maybe more invasive procedures, things that we would more commonly associate with, yes, this was could negatively impact a patient. Next slide. And so why do we even care about birth trauma? Why do we care about mitigating birth trauma? Well, severe maternal morbidity appears to be associated with an increased risk for developing mental health conditions in the future, right? So how do we manage these conditions and how do we support them? And severe maternal morbidity was associated with a 1.3-fold increase rate of hospitalization or ED visits for mental health conditions up to 13 years postpartum. So I think that's something that we don't think about. And I know I didn't know very much about this until Kaylee brought it to the table and really started addressing this within the collaborative. Next slide. So support after severe maternal event, and our goal here is to mitigate further trauma and put patients on a trajectory towards healing. And so how do we actually do this? Again, I'll call CMQCC out as we talked about it. We should actually be focusing on patient-centered care, but didn't really give anyone tools of exactly how to do this, right? So, in an interview of 550 birth trauma survivors, what they came back with consistently was that the incident was acknowledged and that patients were included in a debrief, right? So it wasn't just, hey, this happened, this is what we did, you're lucky to be alive, go home and enjoy your baby, right? But how do we really dig into this and address it and really debrief patients and allow them to process not only the medical steps that happen during that care, but how they are psychologically doing and what resources they might have in the future. It was really identified that the way the medical team speaks to the patients after the event is a piece of their story that they take with them forever, right? So our words are so important. And sometimes where we learned our words, nobody is going to work in this space and saying, I want to traumatize my patients today. I don't want to support them the best way possible. But we learned from a mentor at some point, or we learned from several mentors how we talk to patients after things happen. And maybe that's not exactly what's serving our patients. And so our intention is not to create a negative impact, but sometimes thinking a little bit more about those words and reframing them can truly benefit our patients. It requires us to be a little bit humble, right? And so sometimes that gut reaction from staff can be, I always, talk to my patients kindly, or I always consider their feelings. And while that may be true, sometimes there's some learning associated with what we're saying is actually not being received that way by the patient. And that's actually what's most critically important, right? Next slide. So we do have this document within the toolkit. It's what to say, what not to say, and why. So it kind of addresses these common things that patients hear from providers and staff after a severe maternal event that they have said loud and clear throughout this collaborative and for multitudes of research is not actually serving us well. So we think we're doing the right thing. We think we're framing it as the best way possible, but our patients aren't hearing it that way. And so how do we reframe? Next slide. So we're going to just go through a few of these communication pearls on this sheet. If you scan the QR code, it'll take you to the whole form so you can actually read it. Go ahead and click through. So one of the common ones is everything happens for a reason. And so the patient group suggests this wasn't your fault. Here's what we know about why this may have happened to you. So reviewing some risk factors or maybe even some unknown things. And the reason why this is a good reframing is because, or why that the initial statement is not a great statement to use, everything happens for a reason, is that it's a platitude and it tries to make something positive out of what the patient perceives to be a devastating or negative experience. So it's kind of dismissing the grief and the feelings of trauma that patient's experiencing and kind of diminishing the fact that like maybe I shouldn't be feeling the way that I'm feeling? Why do I feel so defeated or sad or angry or whatever the emotion is? So we want to make sure that we open that up for discussion, and it's much more open-ended than kind of the shutdown where like, hey, everything happens for a reason. Next click. All that matters is a healthy mom and a healthy baby. I think we've definitely all heard this one. We may all be guilty of saying it at one point or another in our care. And so the patient group suggests that we try. I know this wasn't the birth experience that you expected. It's okay to have feelings about that. And the reason for that is that, of course, a healthy mom and a healthy baby matter, but so does the patient's actual perception of the experience of their birth. And that statement kind of dismisses the feelings that they might have about almost dying or their perception that they almost died, right? That they don't know the actual severity necessarily of the case that happened to them. Next click. Instead of you should be so grateful, try something like, I know this might be scary and a lot to process. What questions can I help you answer? Again, that more open-ended invitation for discussion with the patient. The reason for that is there's absolutely nothing wrong with being grateful and happy with the staff and great for all of their intervention and what they did, but kind of that forced gratitude is unhelpful, especially during a severe maternal event. The provider's experience of the event can often differ greatly from the patient's. So for most patients, they thought that they were going to walk into that hospital, take home a baby, there would be no issues that happened to their sister, their neighbor, their friend, and they're having a different experience, and now they're having to process this, right? So yes, of course, they're grateful that they're taking home a healthy baby, or maybe they are not. And so how do we not dismiss those feelings, but again, allow them to process it, not necessarily immediately after the event, but very close to the closure of that event. Next slide. So we decided throughout this work group that instead of calling it a severe maternal event debrief, we were going to change the name to patient care discussion. And there were a couple of reasons for that. One was that staff was like, we already do debriefs. We already do debriefs. And so there was this kind of loss of connection that actually speaking with the patient and allowing the patient to unload or unpack their experience and ask their questions is different than some of, why did we not get blood from the blood bank as quickly as we wanted, or why, was the balloon not where we expected to find it on the unit, right? So those things are super important for us on the clinical side and how we improve those kind of processes, but it's a little bit different than unpacking the patient's emotions and experience, who was with me, who held my hand. All those different things are a little bit different. And so the patients really drove this changing of this name to patient care discussion. So again, it's not just a debrief where we kind of tell them what happens, but we're allowed to go back and forth with this experience. Next slide. So the pre-discharge patient care discussion is really a starting point so that the patient can fully understand what occurred to them medically. So it helps them process the event in its entirety. It provides a space for patients' questions and clarifications. So what was the causes of this, if there were any that we can identify? What treatments were elicited during the treatment of the severe maternal event? And then are there any long-term considerations? And when we kind of open it up this way, we're encouraging the patient to participate in this care, and we're encouraging them to share their feelings, as opposed to saying like, hey, you're doing all right, right? We did everything we could. You're doing all right. You seem like you're doing great, right? So it really allows them to open up and give them opportunity for this conversation, because it seems like we want to hear it, right? We're kind of opening that door. We actually want to hear this information. Preparation for moving forward. What should the patient expect in the next days or weeks? Who can the patient reach out to for further discussion? Is this somebody on the unit? Is this somebody in the clinic? Always the main provider is not always the best option because of availability reasons. Who can the patient contact more readily? And I would say that we're doing this in most units really well for perinatal loss, right? We didn't used to have these robust perinatal loss programs 25, 30 years ago, right? But now we've got these extensive programs where we know our patients need emotional support, maybe not today, maybe not tomorrow, but moving forward. And so we have these contact attacks for patients that experience perinatal loss. And so kind of the challenge is to frame this in almost the same way that patients might not know exactly how this is going to impact them today. But moving forward, we want to make sure that there's a wealth of resources and that we let them know that it's expected that they might have this down the road and where can they reach out for assistance or questions. It doesn't replace any ongoing updates to care. So once we do this pre-discharge discussion and we send them home, it doesn't mean that we're never going to talk about these things again. And it won't replace the need for future debriefing in the office, again, with the main provider or other medical staff. Next slide. So this is an example, and I think this is the one that was shared with you all, the pre-discharge care discussion guide. So you can scan that QR code and go directly to that page. But it really walks you through all the steps of how we're running this, assessing the patient understanding, providing a description of the care, what happened with this specific patient. So we're not just talking about all hemorrhages, we're talking about this one and specifically, pausing for questions and reviewing what to expect next. And I know because we've used resources like this in the past for hypertension and other things, that sometimes there can be a lot of pushback on this where providers might feel like, I'm not going to read through a script when I'm talking to my patients. And the intention for this is not for you to read it verbatim, right? It's for you to utilize it as a guide, add your own little style, spin, personality to it, right? It's just a way to kind of walk you through it. So no one's, expecting you to read this through and make it very canned and generic. It's just how you're making sure that you're reminding yourself that you're hitting all those high points while you use your own language and your own personality in it. And so again, touching back on Michelle's talk, that's why it's super important to practice these, right? With practice comes a little bit more comfort with it. It'll flow a little bit nicer than kind of the generic form. Next slide. So who should be present at the patient care discussion? Well, efforts should be made to include all those that were present at the time of the case. So thinking about, what's available at your facility, who responded to that case for whatever one it was, your obstetrician, perhaps your MFM physicians, additional physician as appropriate in the case, anesthesiologist, intensivist, et cetera. Are there midwives at your facility? Were they involved with the case? Nurses that were at the bedside or in the OR. And if appropriate or possible, that's why I was asking that question about a psychologist, a social worker, or a case manager. So who can help, bridge that gap between this inpatient space that you're in now doing the patient care discussion and that connection with resources. So kind of nice to have all these people in the room or know that this is the ideal model. Sometimes when we present things like this, there's a million, things in the chat or a million questions about this is not always possible, right? It's not always possible to get these people together. This is the gold standard, right? And this is what we should be trying to achieve, noting that it will not be possible 100% of the time, right? Just because something's not possible 100% of the time doesn't mean it's not the standard that we should achieve and try to make space for. So just calling that out. Next slide. So these are a bunch of considerations that we want to think about during the patient care discussion. And it's really that we want to schedule a specific time and include patient support people that the patient designates, right? So we don't want to say, okay, we're all here. We're all here at this particular time. It's 4 p.m. We're going to go ahead in this room and do the patient care discussion together. Now the patient is not prepared for that. They don't have maybe all of the support people they need who might have additional questions, who are going to be providing support for this patient at home after they leave, so that they haven't heard all of this information. And so now they're going to have to hear it secondhand. So you want to make sure that patient support is available. So for some hospitals, they've decided that they do this at a particular time. So let's say they round at 8 a.m. So 8 a.m. is when the patient care discussions happen, maybe the day following or 2 days following the event, so that's kind of a standard time that works in some facilities. And other facilities say, hey, we're going to schedule this for 4 p.m. today. It's 8 a.m. now. Please let your patient support people know so that they can be here and be part of that talk and have their questions answered. So we just want to make sure that we don't pop in and do these discussions, but we actually plan them so that the patient can have there who they want there and who would be most supportive. We want to make sure that we confirmed the preferred language. So if needed, an in-person interpreter is preferred to anything telephone or iPad wise. In-person interpreter for a debrief of a severe maternal event is preferable. Confirm that the clinical care team will be present. So we want to make sure that now we told the patient that this is going to happen at a certain time. Is everybody going to be there? Are enough people going to be there, or does it need to be rescheduled for a different time? We want to clarify who'll lead the discussion, and this can vary depending on the case, who's the best person to lead the discussion. In some cases, it might be the anesthesiologist. In some cases, it might be the obstetrician or the intensivist. So that's something that should be decided before we begin the discussion so that we're not all kind of talking on top of each other. And then we want to review the clinical course and documentation beforehand with those who are involved, especially if they won't be present, right? So if we've got a team member, for example, anesthesia, who is not able to be involved because maybe now they are tied up in an emergent case, we want to make sure that we've reviewed that clinical course and brought any kind of pearls from that team member back to the patient and back to the patient care discussion. Next slide. So this is what we call the patient summary form. You can scan this QR and get to this, but this is something that we fill out for the patient for them to kind of reference. A lot of hospitals have been using this where the patient kind of holds it while we're going through the patient care discussion. They can make any notes on it that they want to make. They can kind of review it ahead of time before the discussion and see if they have any questions, anything that was generated as a result of this form. Sometimes they see a lot going on, or they might hear a lot going on in the room, or a support person might hear or see a lot going on in the room, and they're not sure what that sequence of events was, or was that blood that was hanging, or was it IV fluid, you know? And so this gives them an opportunity to kind of look at that clinical course and see if they have any questions or want to clear up any misperceptions they might have, or 100% accurate perceptions that they have. Next slide. So after discharge following the adverse event, we encourage follow-up with 1 to 2 weeks of discharge with the obstetric care provider. Certainly, if it's something that is hypertension, we know that the patients are seen sooner after that, but this is at least, you know, a guideline for other types of severe maternal events. We want to make sure that discharge summary and the summary of the hospital course is given to the patient ideally, but also sent to the obstetrician or CNM and the primary care provider, again, depending on what that severe maternal event is, right? We know, especially with hypertension, inclusion of the primary care provider is super important. We want the patients to know exactly where to go if there's a complication after they leave the hospital. So do they come back to the ED? Do they come back to the unit? You know, what is the best place for them to report if they have a persistent complication or additional complication? Again, streamlining that they're already going to be in this place of being traumatized by this experience, a little bit nervous. It's not a typical normal discharge, just home with their baby. So we want to make sure we remove as many barriers as possible. And then we want to make sure that we're performing mental health assessments. There's a bunch of validated tools, whichever one your facility is using or your outpatient service is using is great. We just want to make sure that we reinforce that and we carry that out through the care. It should be kind of the default that we're expecting that patients will have some level of mental health needs after a severe maternal event, and not, hey, this is here if you want it. Right? So when we frame it a little bit differently, like there is an expectation that you will need some level of support. You've went through this traumatic experience, or what could potentially cause birth trauma in the future. And so these are all the resources that we want you to utilize or want you to look into, right? Or please contact us and we can work through it together. So really framing that expectation as like, it's more likely that you will need it than not, so that the patients don't feel that there's some sort of deficiency in needing mental health support after a severe maternal event where they were quote unquote saved, right? So I think that framing is super important. And again, how we message that to patients can be really important in how they follow up and follow through. Next slide. So postpartum visit assessments. So we want to make sure that we're going through that discharge medication list and make sure we're reconciling it. I think that's super helpful to do with, again, patient support persons so that everyone's on the same page with what the medication needs are after that. Considering any contraceptive needs, normal postpartum things. Offer referrals for mental health services and other formal support services. and share the benefits. Like this can be really great. I know some hospitals have local birth trauma groups where patients can meet after severe maternal events. Sometimes it's in the next town over, but really investigating that in your area and seeing where local support groups can be in your area is important. There are Facebook groups, there are other online type of groups, and you should know where these are. I find sometimes the social workers kind of know some of these pearls, but they don't necessarily share it with staff. And if you're in a situation where the social worker is not available or not able to answer that question, it is important that just more than the case managers and the social workers know where these services are, and the more local, the better. Thinking about any lactation or baby feeding needs, again, if the birth experience didn't go as planned, we want to try to remove barriers to other obstacles like difficulty with lactation. So is there anything that we can be forward thinking about? Did this patient receive a ton of fluid and now there's going to be possibly engorgement issues with lactation services, and how can they think about that ahead of time? So really kind of looping in lactation, not only in the hospital pre-discharge, but how we refer patients out. And it's important to mobilize that family support system, any community social services, again, which will vary from town to town or county to county. And if doula care is available in your area, postpartum doulas can be super beneficial. Again, they know warning signs of things. They're great at supporting patients after birth experiences, whether those be birth experiences that are typical or whether they have some sort of trauma associated with them. They're great at referring patients back to mental health services. So if that is a resource that's available to you, we highly encourage that use. Next slide. This is the post-discharge care guide. So you had the pre-discharge care guide. This is the one for how we arrange all that postpartum care. This is a sample. All these services may be available in your area or they may not be. So you might want to tweak this document so it fits what you're able to refer to. You can be very specific on your local hospital form and say, this is the number that you're going to give the patient, or this is the website, or this is the address. So you can really tweak this form to be most useful to you. But this really closes those gaps in coordination of care after a severe maternal event. I think this has been a big hiccup in California where, we're doing all the things we're supposed to do in the hospital. We tell patients, go do this in this many days, but that coordination of the care and the actual addresses, phone numbers, appointments is kind of where we drop the ball. So as much as the hospital staff can help with that transfer to the outpatient setting or in the postpartum setting and helping coordinate those appointments, or really even just giving that information, hey, if you get lost in all of this, or so-and-so doesn't call you by a certain time or certain date to schedule that appointment, circle back with us and let us give you that assistance. And again, in your facility, that might be a staff person designated, it might be a case manager, it might be a social worker, but these are important things to have worked out prior to discharge and prior to rolling out this process. You want to include a checklist for follow-up appointments, and then any kind of social support assessment. Next slide. So implementation of the patient care discussion. So again, the how. This is all really great, Christa. How do I make this happen in my facility? Like, what steps can we take? Next slide. So who should help inform the process? So I've given you examples of how it can work, but every facility is a little bit different. So who's going to help inform your particular process? Is it the social worker? Social workers can be, like I said, they've got a treasure trove of information that they often keep, for those kinds of referrals. But is there something they can do to help inform this process so that we make it better? A psychologist specializing in birth trauma. Do we have access to patient advisory liaisons, or is there a patient advisory work group? Again, the wealth of information in the sepsis toolkit for patient resources was created by patients. So is there something locally that you can do that will help inform this process? Is there a community organization in your area that wants to support this, can support it, or maybe is already supporting it and you're not that familiar with it? So all of these partners can help inform your process. Design who that minimum team requires is going to be in your facility. Again, we all have different resources. So who's going to be that minimum team that leads that patient care discussion? When will these patient care discussions occur? Again, what is that set time going to be? Is it going to be ad hoc, or is it going to be 8 a.m. Whenever we need one? And then what resources are you going to bring to that? Next slide. So for resources, we're talking about what will you use to guide the discussion. So what are the staff and providers using to guide that discussion? Are they using that patient summary form that I shared an example with, or some other type of patient summary? What will you provide that patient to really anchor that discussion and serve as something to refer back to? Are there certain handouts that have pictures on them or specific directions or explanations? Are you using models? Are there cases for severe maternal events where a model would be really helpful and showing a patient, what happened to them or what the treatment was? Whiteboards can be useful. We're not all super artistic, but sometimes we can get away good enough with drawing some pictures or to explain to patients exactly what happened or what that process was, and it makes it a little bit more interactive. What external resources or referrals are available in your community and will be standardly shared? Like for hemorrhage, we refer everybody here. For all birth trauma, we refer people here. For sepsis, there's special sepsis groups, so think about that and what's available locally. And the organization of follow-up appointments. So how do you do that? Do you give the patient a handout? Do you assist with appointment making? Is there some other mechanism? Some hospitals have apps, websites, etc. Next slide. So for staff and provider education, the biggest pushback I think I mentioned before is, hey, we already performed debriefs. So it's really explaining how this patient care discussion is different than that clinical debrief, and really sharing what the importance of the patient care discussion is. So we talked about that a little bit earlier, like the long-term impact that birth trauma has on patients. And then sharing the specifics of this established process. So you kind of really need to anchor the people in the why we're doing this before you tell them, hey, this is a new process, we're rolling it out, this is how we're doing it, right? They have to kind of have that buy-in of why this is important, and really sharing patient stories. And there's a multitude of them online of, how patients felt that they weren't part of their clinical care discussion. They don't really know what happened to them. This can be super important, and again, in helping with that anchoring. Next slide. This is a guidance document that really will walk you through the importance of pre-discharge discussion. So you can scan this QR. Again, you don't have to read this verbatim, but this can be really helpful in designing your education of how you pull your staff and providers into really starting to utilize the patient care discussion, and really realizing that this is not like an optional kind of nice to have, but when we're talking about mental health and the future of the patient's mental health, it's actually part of their care, right? So we have to incorporate it in some way. And those ways can be small in the beginning as we get into a little bit broader impact. But we want to make everyone understand that this isn't just a nice to have, but really, really important in the clinical care. Next slide. These are additional toolkit resources. This was a short talk today, but there was lots and lots of resources, again, that were mostly designed by this patient care group. We've got the trauma care flow chart that's used for staff guidance and education. It really walks in that pathway. A guide to recognizing acute stress disorder in the hospital setting. So sometimes we have patients that are not very vocal about how they're feeling or if they're having any issues at all. So what are other signs that we can look for to know that our patients need a little bit more assistance? There is one about sepsis because, again, it was part of the sepsis work. So it's how patients move through the world after they experience sepsis, and then resources for maternal event survivors. So these are, more generic ones that are available to everyone, still reinforcing that those local resources that you might have in your areas or your hospitals, or can inspire, regionally for you to create some of these groups to help patients debrief and be supported long after that severe maternal event and long after their discharge. I think that's the last one. Yay. Okay. So all of our resources are on the CMQCC website. We have everything broken down by topic. So if you look at you'll see quality improvement initiatives. You can go by topic, but all of these patient trauma resources are going to be under sepsis, just so that's super clear.